talking about the new era for hemophilia treatment with, as you see the title, Common Goals, Unique Perspectives. Rather than introducing the panel members, we're going to have each of them introduce themselves. So starting with Dr. Croteau.
Hi, everyone. Dr. Stacy Croteau. I'm a pediatric hematologist and the medical director of the Boston Bleeding Disorder Center, as well as a clinical investigator for many of these novel therapies.
I'm Jenny McDaniel, also a pediatric hematologist in Charlotte, North Carolina.
Oh.
Try that again.
Can we turn her mic on?
I think we got it now, hopefully. I'm Jenny McDaniel, also a pediatric hematologist in Charlotte, North Carolina. I bring the perspective of practicing at a non-academic center, and I'm the director of our Pediatric Hemophilia Treatment Center.
Hello, my name is Cole Cruz. I'm 28 years old, and I'm from Indiana. I'm here as a patient, so I have hemophilia severe, factor A with inhibitors, and I was diagnosed at 9 months old, and I had no prior family history, so no knowledge before me.
And I'm Jen Maas. I'm a pediatric nurse practitioner at the Indiana Hemophilia and Thrombosis Center, and I've been there for 31 years.
All right, thank you for the introductions. And coincidentally, I'm also 28 years old, like Cole. Why are you laughing? Okay. So these are disclosures for all of us. You see the three physicians. We all have disclosures working with different companies. And so this is important. You should get your cameras out. There's also a flyer on your table because this is using the Slido. There'll be some audience response questions. There'll be a pre-test and a post-test. Don't worry. It's all anonymized, so we won't know who got what right or wrong or whatever. And this is also the way you can ask questions. There's also cards on the table. You see there aren't really mics set up, so you can ask questions by jotting it on a card with your pen, or even better if you type it into Slido, and we'll use those for the Q&A session. This activity is actually also for CME, and so using this, before you answer this question, also for your CME at the end, you'll use this. The other thing I want to say is want to thank our sponsor, Sanofi. They provided an educational grant to the France Foundation in order to have this session. So thank you to Sanofi. Okay, well, you're already answering the question, so go for it. So this is our question. We just want to know, who's out there in the audience. So yeah, continue to answer. I see there's 40 plus responses. I guess you could see it as well up at the top there. Let's try to get a little bit closer to who's actually in the room. And remember, you can still scan this QR code or the one on your table. We'll give that a few more seconds. All right. Okay. Well, so we see that we've got just a handful of people from industry. Well, more people than a handful. It's good to see that we've got some academic research hospitals and hemophilia treatment centers. So a little bit of a good mixture here. So these are the objectives of the activity. I'm not going to read each one of them. Basically, the idea here is to try to increase your knowledge of hemophilia, obviously discuss what are the still unmet needs, compare the clinical profiles of some of the new and emerging drugs that you're going to hear from the subsequent speakers, and to assess how these treatments will have an impact on the care of hemophilia. So next, there's going to be a series of questions, which are the pre-test questions. So these are going to be on your phone. They're not going to be on this slide. So now this is the time to look in your phone. Usually I tell my teenagers and my young adult children not to look in their phone, but now I'm going to tell you to look in your phone. So please go ahead and fill these questions out. They're not up here. They're only in your phone. So we're not going to go through them one by one. So if you all can do that, we'll give you a minute or two to do that. Somebody asked me to dance while this was going on, and I said I refused. I'm not going to do that. Then they asked me if I can juggle, and I said I can't do that either. So I'm pretty useless up here. So just go ahead and answer the questions. I don't know, could I put some music on or something? I don't know.
Can you sing?
Can I sing? No, I can't sing either. I'm really, I have a stand-up routine, but it's probably not appropriate to do it here. All right. So, okay, there's a little bit of music then. Sometimes when they do this music, I'm really good at picking the music out. If it's like my genre, like alternative rock and stuff like that. Put on hip hop, I won't know anything. Well, maybe a few things. Beastie Boys from Long Island, where I grew up. All right, we're getting there. We got about 50 plus responses. We have a few more. I'm just going to give you a little bit. This is important for us because we're going to have post-test questions later, and we want to compare, how did we do pre-test to post-test. So if you're wondering why we've taken so much time on here, this is kind of a key component of this education program is to see, did we improve the knowledge? So that's why this part is important. Yeah, I think we're good. So we will now move on to the presentations. And so I'm going to, Jenny's already introduced herself, Dr. McDaniel. So I never come up and talk about adding to our treatment toolbox. Thank you.
Thank you, Dr. Young, and good morning to you all. I'm excited to be here today. Little did I know when I was first becoming interested in hematology as a medical student and resident, especially an interest in coagulation, how dramatically the landscape of treatment options for our patients would change really, pretty early on in my career still. So just an exciting time that also brings with it complexity. Having options and choices does make it sometimes more challenging for us to figure out how to best utilize them for each of our patients. So we'll talk a little bit about the approaches to hemophilia therapy and how they look from a hemostatic and factor level measurement. So we know historically with our traditional factor therapies, we have given factor infusions, the factor level rises, and that correlates well with hemostatic effect. This results, though, in peaks where the patient is hemostatically normal or near normal, but also troughs where there is a lower level of factor and hemostatic effect than there should be and risk of bleeding. We then had the extended half-life factor products that had some modification to the factor 8 or 9 protein that allowed them to circulate longer in the bloodstream. That gave us a little bit more time between factor infusions, but still resulted in those peaks and troughs. So there still is bleeding risk and periods of time when a patient does not have normal hemostasis. With our non-factor therapies, this would include things like our substitution agents or mimetics, and also our coagulation rebalancing agents. We know that with these treatments, the hemostatic effect does not at all correlate with the factor level because these are non-factor therapies. And generally, these treatments are administered subcutaneously, so we don't require IV infusions. And often, we utilize them less. Patients need treatments less frequently than they would with factor infusions. We also see that the hemostatic effect tends to be more steady state rather than peaks and troughs. But because the hemostatic effect doesn't correlate with factor level, that presents some challenges sometimes in how do we best monitor these patients or how do we best evaluate efficacy outside of the clinical outcomes. And then the other treatment that we'll talk about is gene therapy. And the way that this works is a patient gets a single infusion of the gene therapy product with the goal that they could then make their own factor 8 or factor 9 clotting protein. The level of factor that's achieved can be a bit variable and certainly may not be normal yet. But the hope is that we can achieve a fairly steady state, durable factor response and hemostatic response for these patients. One of the unique things about non-factor therapies that we'll talk about a little bit later is that they do hold the potential to treat patients both with and without inhibitors, so have been really game-changing for especially the inhibitor population. So the therapeutic landscape is much more complex now. We have our replacement therapy, where patients may utilize factor infusions on demand if they have bleeds or if they need procedures, or they may be receiving prophylactic infusions to prevent bleeding. For our factor products, we have standard half-life, extended half-life, and ultra-extended half-life products. We have plasma-derived clotting factors and recombinant clotting factors. Some may be unmodified, some may be bioengineered. In our non-replacement therapy category, we have our mimetics or agonists or substitution therapies like emicizumab. And then we have antagonists or our coagulation rebalancing agents. And these may include things like bispecific antibodies, siRNA knockdown, monoclonal antibodies, or bioengineered serpins. And then gene therapy may be delivered utilizing viral or non-viral vectors, and there may be different mechanisms through which the gene editing or addition occurs. And so with the complexity of the therapeutic landscape, one of the questions that then comes up is, are there specific patient subgroups that may benefit more from certain novel therapies? And of course, no talk on hemophilia is complete without the coagulation cascade, so here you go. Our replacement therapy, very intuitive. We are replacing what's missing, factor 8 or factor 9. And that includes, of course, all of our factor products, gene therapy, our extended half-life, our ultra-extended half-life products. Our substitution therapy products that are available currently also serve the same role of factor 8. So they fill that same gap that's missing in the coagulation cascade. The really mind-bending treatment, at least for me, has been the rebalancing agents, because these are such a different mechanism than we're used to. And the rebalancing agents impact some of the natural anticoagulants in the body. So they may decrease levels of tissue factor pathway inhibitor, antithrombin, or protein C. So we'll pause for a minute just to have a little bit of discussion. So first question goes to you, Dr. Young. With the rapidly evolving landscape and novel therapies in hemophilia, how are new therapies evaluated?
Well, I think that's any new treatment that comes to our clinic, could go and talk to patients about. I think that the main point is that you want to see what is the patient currently taking, what are the pros and cons of that, what are the benefits they're getting, what are the risks, what are the challenges. And then you can compare that to whichever new agent just came on the market, and you just, for that individual patient decide, is this something that may benefit them more? Is this something that may have less risk for them? Is this something that's, easier to administer, that reduces the burden of the treatment? So it's always this comparison. We always talk about every new treatment with all the patients. Doesn't mean that they're going to change to that. They may stay on what they're on, which could be fine, but we want to make that sort of judgment. How we evaluate it would be, if they do choose to switch, we will know what the reason was for switching. If the reason was they were bleeding too much on the previous product, then we're going to see how are they doing. We'd have to give it some time, 6 months, maybe even a year, to see how they're doing on the new product. If the reason for switching was the treatment burden was too high, too many IVs or difficulty with subcutaneous injections or whatever it might be, then we'll bring them back sooner and say, okay, how is this administration experience going for you compared to the previous one? So I think the key is when you make a change, to make sure you do the evaluation fairly quickly, and to always go back to what was the reason I changed from one product to the other for that patient, and see if that change has affected a positive change.
And I would just add, maybe taking a step back from a clinical trial perspective. Am I on? Yes. Yeah. Oh, I can hear myself. Brilliant. From taking it back a step from a clinical trial perspective, of course, we're treating bleeding disorders. So we have to ensure that our therapies prevent or treat. Most of these newer agents are in the category of preventing bleeding, of course. But I think it's also important to remember a few things. One, our World Federation guidelines state that prophylaxis is standard of care. So as we think about clinical trials now and upcoming clinical trials, these arms that take advantage of patients living in substandard of care positions where they're only on demand, I think we really want to think carefully about how those are integrated into clinical trials and really trying to elevate the standard of care or to the standard of care for everyone. But I think looking at annualized bleed rates becomes a very fundamental element of how many of the primary objectives are set. And while we will talk more about getting beyond the concept of bleeding rates, I think it is important to remember that fundamentally we do need to demonstrate that these medications do a good job preventing bleeding, at least as good, if not better, than our currently available therapies, both from a clinical trial perspective and, as you highlighted, certainly in a clinical perspective. And as we move to this, everyone adequately being prophylaxed, lowering the bleed rates across the board, thinking about other elements that are really crucial, ease of administration of treatment, ease of adherence to treatment, improvement of quality of life also becomes really important metrics for us to evaluate some of these therapies on as well.
And I think we know there may be other concerns related to some of these new therapies when we're thinking about how we might manage surgeries or procedures or bleeding events as well. And we just have to be very thoughtful about there may be differences that will come up with some of these newer agents, especially in how we approach our management for those patients.
Absolutely right. We go beyond just the easily, readily available factor 8, factor 9 activity levels and have to think more about potentially integrating our global measures of hemostasis or novel global measures of hemostasis, bringing them into being more clinically ready, because presently they are not clinically available for most individuals. There may be areas of your hospital or certain hospitals that have worked to standardize the assay within that center, but certainly not something that's readily available across even large institutions, let alone the smaller community hospitals that may be a first point of stop for many of our patients as they're traveling or living great distances from the bleeding disorder treatment centers.
And then I have a question for Jennifer as well. With how rapidly the treatment landscape has evolved and how many new products that we have and that are coming soon, how and when are you trying to educate patients and families about these new therapies?
Now, that's a great question. And I think when we think of patients and families, they're all different. They all consume information in a different way. Some are on social media. Some are very savvy and knowing what's happening. But from our center standpoint, the first thing we want to do is when we know that a new product's coming out, preparing our staff. Because whether our patients find out about it the first time from us, when we always send a letter when a new product comes out. But in a lot of cases, that's not the first time they hear about it. And they're calling in, and the first person that they get is the nurse on the phone who they may be asking questions too about the product. So it starts with really part of your plan is making sure your staff and everybody who's face-to-face with those patients have some idea or at least have a point person to refer the patient to. But then developing some strategies where not everybody reads a letter in the same way. So then how do you, as you see them in clinic, how do you have those conversations? Or is there a product that somebody's struggling because they've called in with difficulty with the current treatment product that they're on? And is that a good time to then have, again, another conversation about the product? So it's really multi-tiered. We always start out with sending a letter, making sure our staff and the people who answer the phone can have at least a point person or knowledge about what they're talking about. And then also approaching people that we feel like would really benefit at the times when they might really benefit from it, like they're having bleeding, or when we see them in an appointment in the clinic, but not everybody is going to be. Once a product is licensed, not everybody has an appointment within the next 30 days. So really kind of working on a multi-approach about a new product, especially if you feel like there's a good benefit for the patient.
Great.
I'm sorry, Cole, not to put you on the spot, but as I was listening to Jennifer, I'm curious from your perspective, how do you like to receive that information? So, or even as you're, thinking about other members of the community that you've spoken with, do you enjoy hearing about or prefer to hear about these new therapies while they're still kind of in clinical trials and possibility? Do you prefer not until it's available to me or potentially something that might benefit me? What's sort of your perspective on how you'd like to receive some of that information?
Yeah, I think it definitely just depends on what position you're in. Like, if I'm being treated great and everything's going great, I'm getting few bleeds, and life's good, then I'm probably not that into looking at new therapies. But if I'm getting bleeds every day, I'm having issues, then yes, I'm going to be a lot more apt to, go online, do some research, or call the HTC and get some more information.
Great. Thank you. Okay, so we'll just talk a little bit about tried and true. We know factor replacement therapy very well. There are still some patients that are using on-demand treatment. We know some of our mild patients and perhaps some of our more ornery older adults or challenging adolescents. But that's the infusion of the deficient clotting factor just at the time of bleeding or before procedures. Hopefully, most of our patients are on some sort of prophylactic treatment, which we know is just regular infusions of the deficient clotting factor with the goal to prevent bleeding episodes rather than just being reactive or being proactive. But even our most adherent, compliant, perfect patients that are doing their infusions right on time, there are still peaks and also troughs associated with factor infusions. And so breakthrough bleeding remains a risk. Our factor replacement therapy, we have, short half-life or the standard half-life therapies, the extended and ultra-extended half-life therapies. Our standard half-life products are limited by the shorter half-life. Patients need frequent IV infusions, and of course, we have peaks and troughs. There are benefits with our extended half-life therapies over standard half-life therapies. We know patients may be able to get by with fewer infusions. They may achieve higher factor trough levels and also hopefully decrease bleeding with a substantial reduction in their ABR. In the table on the right side, we've listed out the different products. They're all very fun to pronounce, but I'll let you do that on your own time. So our standard half-life products, we have several for hemophilia A, 2 for hemophilia B. For our extended half-life products, there are 4 for Hem A and 3 for Hem B. And then we have the newest on the scene, ultra-extended half-life product, which we'll talk about in a little more detail. So efanesoctocog alpha is an ultra-extended half-life factor 8 product that has been a game changer for patients with hemophilia A on prophylactic factor infusions or using on-demand. And the unique thing about efanesoctocog is that it has an additional modification to the factor 8 protein that allows it to circulate independent from von Willebrand's factor. So as we all know, usually in the blood, factor 8 circulates in conjunction with von Willebrand's factor. And the half-life of factor 8 has been limited by the clearance of von Willebrand's factor. So this additional modification to the factor 8 protein has significantly extended the half-life. So we're seeing that patients can receive just once weekly prophylactic factor infusions versus multiple times a week with the other factor 8 products. And generally are achieving higher factor levels throughout the dosing interval with a trough level above 15% for patients, which is just unheard of with all of the other products. So patients that are struggling with adherence to their prophylactic factor therapy, especially thinking about my adolescents, may benefit from an ultra-extended half-life product due to less frequent dosing requirements. For our substitution therapies or our mimetics, we have imicizumab, which is the only therapy currently approved by the FDA. It is a bispecific antibody that serves the same role as factor 8. So it brings together 9A and 10 to facilitate coagulation. As you recall from one of the prior slides, though, we know that the substitution therapies generally achieve a fairly steady state hemostatic effect that does not correlate with the factor level because it's not factor VIII, but it is not yet achieving a normal hemostatic effect. And so breakthrough bleeding is still a risk with emicizumab. There are a couple of other factor VIII mimetics also in the works, so MIME-8 and NXT007. Emicizumab, and all of these products are delivered subcutaneously. So emicizumab can be delivered weekly, biweekly, or every 4 weeks. MIME-8 delivered weekly, and NXT007 TBD. MIME-8 is in phase 3 trials, and NXT007 in earlier phase trials. Emicizumab has become the most commonly prescribed medication for prophylaxis for hemophilia A. And then the other comment about the other two mimetics is that in preclinical studies, they do show increased thrombin generation compared to emicizumab. And it will be interesting to see how this pans out with regards to bleed prevention. The other unique thing for our factor VIII mimetics, as we touched on earlier, is that these can be utilized for patients with inhibitors. So this was a game changer for all of our Heme inhibitor patients. It serves the same role as factor VIII, but it looks differently. And so patients with or without inhibitors can utilize this class of products. It also may be beneficial for patients who are physically active, involved in sports, because there is that more stable hemostatic effect compared to factor infusions, at least the standard and traditional extended half-life products. Okay, a couple more panel questions. So my first question is to you, Cole. What items are important to you when you hear about new therapies?
Yeah, whenever I hear about new products, I guess the first thing that comes to mind is it effective in the short term, like with my bleeding and with my everyday activities? So is it effective? And then the second thing I think about is how many times do I need to infuse? Like when I was first born, right, I had a port. So I went from a port to infusing every single day in my vein to now once every 2 weeks, in my stomach kind of thing. So that's something I would think about. Is my infusions going to be less or more? And then the last thing I think about is it safe and effective for the long term? Like, what are the long term effects of that medication, if there are any? And if there's any kind of data, I would like to see that before jumping ship.
And then tell me a little bit also about like your activity level and how that might impact, what's important to you with regards to therapy. Like, were you playing sports? Are you active?
Yeah, I would definitely say if you're active and if you play sports, it is by far more important to be on a drug that's going to have less bleed or keep your bleeds in good management, right? Because you're going to be getting a lot more. And so my whole life I played sports and I still play sports, and it's definitely something that you always need to keep on the top of your brain, when you're playing anything. You never want to miss a dose. And if you do get injured, you probably need to do the right things to probably call the HTC or, use your medications the way you're supposed to, all those kind of things.
And then last one for now, I promise. But I'm also curious, how much does the ease of administration matter to you? Like, how much easier is a subcutaneous product versus an IV infusion, in your opinion? And how much does that impact your decision making? So, like, would you accept a higher bleeding risk, a little bit higher bleeding risk, if it's a lot easier for you to get the medicine or not?
Yeah, I'd say that's probably one of the biggest things. Growing up, I had peers, with the same thing. And, some families, they just wouldn't be able to hit the vein, and so they would miss doses all the time, and all those kind of things. I would say that's super important. If I could go on a drug that would make it less and easier, for sure. Yeah.
Okay, Dr. Croto. What systems can be set up to monitor issues related to the use of new medications?
So I think we have some systems already in place. MedWatch, for example. So for unexpected or atypical side effects of medications, of course, bleeding doesn't count as a side effect for bleeding disorder medications. But certainly, and we'll talk about this a bit more in the next section, clotting complications and what have you. I think also doing a better job taking advantage of the networks that we have across the bleeding disorder treatment centers in the U.S. And certainly they've done this much more effectively in Europe, and collecting the data across the centers, looking for rates of bleeding, rates of other complications, joint health for longitudinal monitoring are really important opportunities that we're really not maximizing at present.
An app for monitoring.
That we're really not maximizing at present.
Yeah, I know. I was just saying also Athens.
She was saying about Athens a lot too. Okay, moving on.
Okay, next section. All right, Dr. Credo.
Before Stacey starts, just a reminder that using the QR code, you can also ask us questions. There's also cards on the table. So if you asked a card on the table or filled out a card on the table, just kind of raise your hand. Somebody will come and pick it up. But on the app, there's, like I'm looking at it now, there's a place that says ask, and you can click that when you ask your question. So we just want some more questions coming through. Yeah, Stacey, thank you.
Excellent. So we'll continue on in the novel therapies, now focusing a bit more on the non-factor therapies that Dr. McDaniel already started thinking about rebalancing therapies, and then also highlighting just high level a bit about available gene therapies. So this has become a common schema that is put forward as a conceptual model for how we can think about rebalancing therapies, where we have procoagulant clotting proteins, 8, 9, etc., as we've highlighted here on the left-hand side of the screen, as well as other regulation of hemostasis, coagulation inhibitors, so antithrombin, tissue factor pathway inhibitor, protein C, protein S. And as we're aware, in our usual homeostatic state, ideally the relative balance of the effects of these two arms of the coagulation system are well balanced, such that as soon as we have any minor injuries, our clotting system is primed to activate itself and quickly deploy platelets, clotting factors, to avoid us from having exsanguination from minor cutaneous injuries, from bleeding into our joints or bleeding into our muscles. And at the same time, we have the counter-regulatory proteins, as you see on the right, to halt that process so we don't quickly turn into a full-body thrombosis. And certainly as we eliminate procoagulant factors, here we've eliminated factor 9, you see a tip in the balance. So as you eliminate procoagulants, you end up with bleeding diatheses. And on the opposite side, if you eliminate anticoagulants, here denoted by the removal of antithrombin, you end up with thrombotic disorders or thrombophilias. So the idea of the rebalancing therapies is to enhance hemostasis by reducing or inhibiting our natural inhibitors of coagulation. And you can see this here. For example, hemophilia A, deficiency of factor 8. If we then begin to remove one of the coagulation proteins, here highlighted as reduction of antithrombin, can we achieve this goal of restoring balance without causing abnormal bleeding symptoms and also without causing abnormal clotting symptoms? So can we get this balance right? But as many of you, especially the practitioners in the audience, can appreciate, hemostasis really isn't a balance beam. It's this multi-directional balance board where we have multiple impacts of both the pro and clotting factors within the pathway. We also have influences of inflammation, of injury, of surgery that alter the homeostasis and alter the interaction between these proteins. So it's not as simple as I've removed this much factor 8, therefore I need to reduce antithrombin or protein C by this amount. It's a much more dynamic system. When we think about the rebalancing agents currently in develop, and we've now actually started to see these agents move into licensure, there are 3 that we will highlight today. The first listed here is a medication called fitusiran. This medication has a mechanism of action of reducing antithrombin through a silencing RNA mechanism. It's able to be administered subcutaneously, monthly, bi-monthly, currently still in phase 3 development. There have been thrombotic complications with this agent, leading to 2 halts, actually, of the clinical trial program, helping us and giving us the opportunity to figure out how do we do a better job getting this balance right. And so have led to things like altered dose of the administration in terms of how low we want to drive antithrombin levels, and how do we get the dose and the frequency of the dose just right to try to keep individuals in a potential sweet spot of reducing bleeding, but not putting them at significant risk of thrombosis. Also a challenge of also sort of that challenge of frequency of administration and kind of fixed dosing, as you see highlighted there. The other general approach that is furthest in development is anti-TFPI inhibitors, so anti-tissue factor pathway inhibitors. And the strategy that is being used presently are monoclonal antibodies against portions of TFPI, namely the Kunitz domain or the K2 domain. Concizumab is not yet FDA approved and actually did receive a complete response letter from the FDA a few years ago, but is approved in other countries. For example, in Canada for hemophilia B with inhibitors. I believe it's also been approved in Switzerland for Hem A and B with inhibitors, in Japan for Hem A and B with and without inhibitors. So we are starting to see licensure in other regions. It's administered subcutaneously as a daily injection. Is a weight-based dose, and as you see here, is approved in some countries. This program has also had some challenges with thrombotic events leading to temporary halts of the clinical program and need for readjustment of consideration of dosing, thinking about the achieved concizumab plasma levels as a way of altering the dosing. And also, similar to fitusiran, thinking about our approach to bleed management. So rather than using standard approaches to factor replacement in the setting of a bleed or bypassing agents in a setting of a bleed, there are tables that provide some alternative dosing, max doses, max number of doses as guidelines to try to mitigate or prevent bleeding symptoms, again, without pushing individuals into that clotting domain. Mostazumab was recently licensed in the United States for hemophilia A and B without inhibitors in individuals greater than 12 years of age. It's administered as a subcutaneous weekly dose. This program, though similar in many ways to concizumab in terms of mechanism of action, has not had any reported thrombotic events to date and has not had any halting as a result of that. This medication also has a standard non-weight-based dosing with a loading dose provided up front and then standing dosing weekly thereafter. So these, in aggregate, can be opportunities for individuals who struggle, as many would, with regular intravenous access, those who have arthropathy of the elbows, those who have difficult to access veins, those who have just tired and worn out veins after year, decade after decade of IV infusions. Also for those that, despite all of the best efforts with adherence, with optimizing factor levels, aren't achieving effective hemostasis and are still having frequent breakthrough bleeding despite, say, factor prophylaxis. And also, though not yet licensed in the U.S. for this, all of these options provide a potential prophylactic opportunity for individuals with inhibitors, because since they are not impacted by the inhibitor, they're rebalancing hemostasis and affecting hemostasis in a different way, provide an equal opportunity, as it were, for rebalancing the coagulation cascade and providing a prophylactic option for both inhibitor and non-inhibitor patients. So let's ask our panel a little bit more. And maybe Dr. McDaniel, we can start with you. As you're thinking about this additional category of therapies as prophylactic options, what are some of the important considerations that you have taking into account sort of access, surgeries, and procedures, kind of the right patient that might benefit from this category of therapies?
So as a clinician practicing outside of an academic center, can you guys hear me? Yes? Okay. As a clinician outside of an academic center, I think one of the first things I ask is this medication accessible to me? So has it been approved, or, would I potentially collaborate with another center to enroll a patient on a clinical trial? So is it accessible? And then, of course, very important to know, is this treatment going to be effective for my patient, and how does it compare to what they're currently on? In my practice at most community centered, with these yalls there's one small that I've been built working to the storage additional clad the legislation have some cancers that I've been on. And they have a lot of those collaborating rate or just like Jurvats, and that's something with that by Nava. Yeah, that you remember eating about some good there are there. And told to diets that have definitely got a lot of like all good benefits. Are there such a special is that intention that are belonging to the risks? And then in my practice, there's also have that I'm young. I want the so recall. And are there variations in such way at the Vinyati guy that you should see is not there? Where's our sites was blister situation? And if I catch both element and listen what you just very and when we would be knowing able in one sister that that's tacos that we got done so this
So I think you highlighted two really important elements. So first of all is laboratory monitoring, what laboratory monitoring is needed. The second, of course, being the multidisciplinary nature of what we do. So from a laboratory monitoring perspective, it strikes me that you have two categories. One is emergency. What do I need to know in an emergency, and how can I get this? And the other is what might I monitor as part of prophylaxis, or just to sort of understand the general hemostatic balance. So I'm wondering if you can talk a little bit more about kind of that concept of like emergency management versus, the kind of proactive routine management where, sending it out and getting a result back in a week or two or a couple of days, because I see those as sort of different elements, perhaps.
Absolutely agree. Very different settings. And, if this is routine pharmacokinetic testing or something like that, it's fine to wait 7 days to get my assay back. However, in an emergency setting, or if a patient is, needing some sort of major surgery, I really may need much more real-time monitoring. I certainly don't want to sit and wait for bleeding, and that be my sign that I need to change something.
Absolutely. And then maybe we'll pick on Dr. Young to answer the second important thing that you brought up, which is the multidisciplinary nature of. So whether it's other colleagues who might be taking the first call, or our emergency medicine colleagues, or our surgical colleagues in an urgent situation, what are some things that you have either taught your patients, Dr. Young, or some different things you put in place either within your medical record or within your systems to help elevate this level of communication and awareness of these novel therapies in a rare population?
Yeah, no, I think that's really important. We have, for each patient, whatever agent they're on, we will provide them with a bleed management guideline for how to handle bleeds. So obviously, it'll be different if they're on a factor product, versus a rebalancing agent. The dosing may be different. So that's the first thing we'll do within our team. In our medical record, and it's an international meeting, but we use medical record that's run by a company called Cerner. If there's anybody here from Cerner, I'll tell you it's really bad. The other one is much better. But within that system, there's something called a stick.
Not a sponsor, clearly.
What did you say?
Said not a sponsor. Clearly.
No. Cerner's not a sponsor. I'm not going to mention the other system. But the point is, so whatever medical record system you have, there's a way to put something called a sticky note, or they call them different things. We could put a note where if somebody goes to the emergency room, and it's an unusual diagnosis, the emergency room is trained to open that up and see, what information they need. To be honest, we have, a hemophilia or hematologist on call 24/7 in our place, but some of other places will have an more oncology-oriented person on call. So I think it depends also on your setting. Is it all hematologists who kind of know something about hemophilia, or is it more Oncology people are going to be less comfortable. But I think having a plan that the patient knows the plan, that your team knows the plan, and then that's documented somewhere where people can know where to look for it, I think is the key for that.
So cool. Of course, I'm always interested in the patient perspective also on these matters. So you've really articulated very nicely how you think about some of the risks and benefits, how ease of administration, reduction of bleeding is really important to you. But as you hear the concepts of these non-factor therapies, different mechanism of action, different considerations for how we might monitor or understand risk of bleeding or clotting from a medical perspective, how does that also influence your decision-making? Is that something that, if you were close to the hemophilia treatment center, close to the experts, you would feel more confident in versus if you were living many hours from the center? Do you feel like does distance not matter because of the systems that you have in place and the communication amongst your team members?
Yeah, I'd say maybe it's a little bit different now with all the telehealth and things, but like growing up, I lived 2 hours away, maybe even more from the closest HTC. So it was almost a burden every single time I had a bleed or got hurt, because then we'd have to make that drive and make that trip every single time. So it's definitely a burden. I feel like the closer you live to an HTC, almost the better it would be. So pretty much living so far away, you had to get proficient with doing your own infusions, because let's say you live close to an IHTC and I'm missing the vein all the time, I can just jump in there and they can do it for me, and then I can go on about my day. Well, if I live 2 hours away, it's all on me. So it's like there's no such thing as not. I mean, if you miss, you got to go again and again and again and try. You know what I mean? So yeah, I feel like the closer you live to a treatment center, the better, and it would only increase the communication.
And Jennifer, your center takes care of all of Indiana, right? And so, many centers, you have patients coming from a big distance. How have you leveraged techniques like Dr. Young mentioned in terms of the medical record or patient education seats, or like Cole alluded to, telehealth? How are you helping patients and families with access with these kind of more novel type therapies?
Yeah, that's a great question. And I think it starts out with making the patient as independent as possible, as we've talked to, as Cole has mentioned. In our state in Indiana, our most distant patient is probably 3.5 hours. None of our hospitals are connected where we could just pull up a common medical record. So one of our solutions to that, which I feel like these outside facilities really appreciate, is if a patient needs to go to an emergency room or to be seen locally, they're calling us first, the patient. We're proactively calling ahead and saying, this patient's coming to you. In most cases, we can't give orders at their institutions, but we can give some strong suggestions. And it's a lot easier if they'll let the patient bring the products in that they need. Some places will do that, and some places aren't so anxious to do that. But it helps if they don't have the product at their institutions, because we have a lot of small hospitals around in Indiana. And so I think it's about that patient education. It's about having a plan where the expectation is that the patient's calling you before they go somewhere, and then you're calling the ER or the place that they're going to really give them a heads up and make them feel a little more confident that this patient's well managed and you're a good resource for them.
So it certainly sounds like the rebalancing therapies as a category, great potential opportunity. Subcutaneous, less frequent, bleed mitigation, but a lot to think about in terms of laboratories, patient education, access to the center, communication with other members of our kind of broader clinical teams. Let's turn and talk a little bit about gene therapies. So, of course, the goal of gene therapy is to compensate for the dysfunctional gene, in this particular case, factor 8 or factor 9, and introduce an exogenous functional gene to quote-unquote cure or at least ameliorate the phenotype of the disease. Certainly the ultimate goal of gene therapy would be to cure and eliminate the disease. The image here represents the most, the earliest and most frequently evaluated gene therapy strategy that we've used for hemophilia A and B so far, and that is an AAV-based approach. So you can see the DNA coding for the missing or defective factor 8 or factor 9 gene there to the left. In the AAV approach, we gut an adeno-associated virus and integrate the gene of interest within that vector, within that capsid. And then with the AAV approach, it's what we call an in vivo gene therapy, where it's administered through a one-time peripheral vein infusion. The design of the AAV capsid is such that it hones to primarily hepatocytes or liver cells to give the genetic payload, the factor 8 or 9 gene, to that hepatocyte. The vector capsid as well as the gene is taken in by the hepatocyte. Ultimately, the AAV capsid is broken down and eliminated by the liver cell, perhaps generating a bit of a capsid immune response at days and weeks following the gene therapy. And then the genetic material goes to the nucleus of the liver cell, where it's able to capitalize on the liver cell machinery to make functional factor 8 or factor 9, which is then secreted into circulation where it can be leveraged by the coagulation system. Importantly, the goal and the vast majority of this genetic material, while it sits in the nucleus, does not primarily integrate into the host DNA. It certainly does not integrate and replace the factor 8 or factor 9 gene at the site where the native factor 8 or factor 9 gene is. It simply leverages the machinery. So the challenge there being, especially in organs like the liver, where we have great growth from childhood to adulthood, and even as we get into adolescence and adulthood, the liver has an amazing capacity for regeneration with injury. But in order to have those daughter liver cells carry forward the genetic material, it has to be within the host DNA, which means that this extra DNA just sitting within the liver cell nucleus does not get replicated, does not get passed on to each of the daughter cells as the liver is growing or regenerating. So therefore, over time, if the liver cells that have that exogenous factor 8 or factor 9 material die, become quiescent, etc., you would lose expression of that genetic material because it's not carried in future cells and continuing to propagate. We currently have 3 licensed AAV gene therapy products in the U.S., and these have been also approved by many European countries, EMA, and Canada as well. We have one, as you can see there, one product for hemophilia A, Baroctocogene roxaparvovec, and 2 for hemophilia B, kind of all approved in series from 2022 and on. And in this image, you can get an overall sense of what the internal aspect of the genetic material looks like. So the N-terminal repeats there are native to the AAV, but the promoter region, the factor 8 or 9 gene construct is highlighted there. What makes these factor programs different, of course, are some of the proprietary changes in codon optimization of the various gene products of the promoter. So not all of these products are exactly the same in terms of the details of the genetic material being brought to the liver cell. And they're also not all exactly the same in terms of the way the liver cells seem to handle them. It is important to remember that the hepatocyte is the native producer of our factor 9 clotting protein, but it is not the native producer of factor 8. Factor 8 is natively produced in liver endothelial sinusoidal cells. So while hepatocytes clearly, because we've had great success so far, or at least some success in the hemophilia programs, can make and secrete factor 8, it isn't the native cell. So some of the differences that we see in terms of the overall efficacy, immune response that differ between the hemophilia A and the hemophilia B platforms may in part have something to do with the native elements of how these proteins are usually produced and secreted. So Jennifer Moss, we will go to you. When we think about the gene therapies, what has been your experience with helping patients kind of navigate this decision to pursue gene therapy versus clinical trials versus factor replacement?
I think it starts out with how the patient comes to you. Like, are you introducing gene therapy newly so you can have all your talking points and discuss it with them? Or are they coming to you because they saw that there's a cure and that's what they want? So it's kind of like having that, stepping back, having that decision or that discussion with them. It's like, for example, what's their progress on their current treatment. Are they having breakthrough bleeding? Are they failing? And what's their expectations of success for their treatment? Do they feel like that they're going to be cured, and once they're cured, they will never have another problem again? So I think it's really having those discussions about the steps that are required, the frequent lab draws that are needed, talking about the use of prednisone that may or may not happen. What are their plans for if we did it today? What are your plans for the next 3 months when we're going to be watching you really closely to make sure you're successful? And how do we set up the ability to do that, the laboratory monitoring that's needed? So I think that it really requires a lot of discussion ahead of time for a patient to truly understand what the results are, what the results may or may not be. And are they willing to really have the long-term kind of the needs that the follow-up is needed, and do they understand that? So it comes with a lot of different things. Like I said, if they come to you and they automatically think this is an easy cure, it's just an infusion, and then I'm on my way and my life will be perfect from then on, that's probably not the best person to all of a sudden try to get approval for gene therapy, because there's a lot of work that needs to be done in between. So it's a process. And what we found is, it's a process just getting approval from insurance. And so that gives you some time to really start having those discussions and making sure that you're well set and for your patient once you have it done.
And Cole, at the top of our conversation, you very reasonably sort of stated, for me, if I'm on a particular preventative regimen, particular prophylaxis regimen, and I'm not bleeding, I'm less interested in hearing about all the other possibilities because I've got my routine, I'm doing well, I'm not breathing. Hopefully you're breathing, but not bleeding. So, I got lots to do. I don't need my comp to be another hour longer hearing about all the potential possibilities. But when we think about something like gene therapy, where rather than doing an injection every 2 weeks, it's a one-time infusion, perhaps a bit of a, not perhaps, 100% a more intensive experience over the next 6 to 12 months, but then perhaps a similar amount of protection without the need for any infusions. Is that something you would like to hear more about, or what are some of the features of gene therapy or these other therapies that, even if you're not bleeding, might be worth your time to hear a little snippet about in your comprehensive visit?
Yeah, everything you said is definitely valid. Why leave if everything's working great? But the gene therapy, the end result sounds amazing, right? It's almost like you don't even have hemophilia anymore. So it would totally be worth it. Now, I wouldn't jump ship until there's enough data that proves that it's completely effective. I would hate to be the guinea pig for something like that, but if the data's there and it's completely safe and there's a lot of people that's done it already and it's almost guaranteed for me to have a better quality of life, I would definitely do it.
And Dr. Young, as individuals have come to you, I think similar to my institution, while we're pediatricians, we see adult patients and often run, the adult clinical trials as well. For adult patients coming to you, or even those 16, 17, 18, that getting close to the 18-year-old cusp, curious about this, what have some of those conversations been like as you've tried to guide them in terms of the utility of this or potential utility of this in their prophylaxis?
Yeah, we just get very practical, and we talk about, like I said earlier, with new treatments, what are the advantages? What are the potential disadvantages? What are the benefits? What are the risks? And compare it to their current treatment. Some of my patients felt they were doing great on what they're on. They were comfortable with it. They weren't ready to be a guinea pig in a sense. I kind of don't really like that term. But in a sense, they didn't want to be one of the early adopters, even though I've told them that there's been, if you take all the gene therapy trials together, hundreds of patients with hemophilia have received gene therapy to this point. And then there's others who are like, wait, it's one infusion, and then I won't have to poke myself, either subcutaneous or IV, for at least years, which, if you look at the clinical trial results for most patients, they go off prophylaxis at least for some years. and many have gone off prophylaxis for 3, 4, 5 years. So some of them just their eyes light up when when you tell them that. And so I can kind of be like a normal individual, not really worrying about my hemophilia as much. And I kind of walk them back and say, well, no, I mean, we'll have to see how you respond and all that. And we talk to them about the process because there is some burden associated with the process of not so much the infusion itself, which is, a 1-day process, but the lab testing after. So I've had all kinds of responses from, I don't want to hear about it, to when can I get it? And everything in between of curiosity. So the way I view gene therapy is it's another treatment option, along with all the other treatment options we talked about today. We have some that are already available. We have some that are soon to be available. In the next, few months, most likely, we'll have at least 2 other options available in the U.S. from the rebalancing agents. And so I view gene therapy as one other option for treatment, not per se, oh, gene therapy is here and then all the other treatments options are here. To me, they're all in like one sort of category of hemophilia treatments, and then approaching the patients and discussing kind of what I already discussed.
Stacy, can I add one more thing? So we had a patient that we did this week at our place that was outside of a clinical trial. And one thing that I didn't think about, his wife was really overwhelmed. He was a very laid back guy. All the discussions probably had to do with him and focused on him. And on the day of the infusion, it was just very difficult for her because she was afraid for him and what's next and that kind of thing. So really involving the whole family, the key decision makers, and making sure everyone's a little prepared. I mean, it definitely, next time we do it, we will be looking at that a little more than we did before this time. And then the other thing is making sure they come in the night before, because the last thing you want to do is have a snowstorm or something where they're not going to be where they need to be when they need to be there.
No, I think that's perfect, because it kind of dovetails what I was going to also ask Dr. McDaniel a bit. I know we may a little later get into like the logistics of, gene therapy and the follow-up, but even as a preparatory or as presenting the option, how do you approach that at your center?
Yeah. It is something where I do think it is ideal if patients hear about new treatments from their HTC rather than, social media or other sources. So I do make an effort to kind of do at least a cursory overview, maybe not an in-depth of everything, but a cursory overview at their comp visits. And, for me as a pediatric treater outside of an academic center, we have not yet done the gene therapy infusion. I have a 7-year-old whose father is chomping at the bit, who is ready to go whenever he can. And, it's something that we certainly have brought up conversations. And, I introduced the concept. We talk about, there are, of course, outcomes are not guaranteed. There is a good bit of monitoring, especially in the beginning, that needs to be done. And, right now, for the majority of my patients, they're not yet eligible for commercially available product, at least. And I was actually just curious, for those of you that have done gene therapy, I was wondering what sort of psychosocial evaluation goes into the prep as far as getting a patient ready. Because, again, we know, the outcomes generally are favorable, but not guaranteed. So not all patients, achieve independence from factor infusions. And we know, steroids can come with a lot of emotional side effects and physical side effects if those are indicated. And then, depending on how far the patient lives from an HTC, monitoring. So I was just wondering what sort of psychosocial evaluation you have before gene therapy is done.
I'm happy to start.
Yeah, I'll just say one thing really quick, though, is that, with all treatments, obviously you go through the pros and the cons, as I already mentioned. I think gene therapy, the one area that's a bit different is you really need to set expectations, right? So you need to set the expectations for what the outcome could be, positive and negative or in between, as well as setting the expectations for what is required post-infusion. So I think more than the other treatments, which you can, you start one, I don't like it, you can stop it. Yes, emicizumab might take a few months to come out of your system, and some of these other ones may take a bit longer. But bottom line is, you can start a treatment and stop it, and eventually it'll be out of your system. Whereas gene therapy, once you get it, you're for better or for worse, you're stuck with it. Mostly it's for better. but just really setting the expectations for, what's going to happen during the infusion, which is really less of a concern. Yes, there's infusion reaction, but that part's actually easy. It's really the post infusion, setting expectations for the potential outcomes and the steps that are required and the things to avoid.
And I think that there isn't one standardized approach to the way that we, for better or for worse, sort of approach this really important aspect across gene therapy programs or across centers. But I do think that part of the value of the Hemophilia Treatment Center, both even the pediatric centers into the lifespan centers or the adult centers, is that comprehensive model that we have throughout. So these individuals, if they're treated at hemophilia treatment centers, have had a social worker as part of their team since birth. And hopefully that social worker has done a great job of handing over, if they are now in an adult center, to the adult social worker. So in addition to the medical assessments that we do, to the often multi-step education and preparation that we do, having the social worker present and alongside, following or preceding each of those types of visits with a discussion focused on these issues, I think is really important, because at the end of the day, the amount of time, the number of visits, the exact preparation is really going to vary from patient to patient, depending on their lived experience, their expectations, their own system. And so I think we have to leverage the multidisciplinary HTC team to really be sure we're tailoring our education and our approach in that way. And I think that extends to caregivers, spouses, potentially parents, depending on how young, even my 18 to 22-year-olds meet the letter of the label for participating in gene therapy, but we still have adults. We still have parents very involved in their decision-making process in many cases, and involved in the lives and making sure that we're really treating the whole person and the whole family and caregivers, I think is really important. So just a little snapshot of frequency of use. So when we are kind of pulling a lot of these therapies together in a consideration, you can see the drug, the therapy in the column there to the left, factor replacement, the factor 8A mimetics, the rebalancing agents, gene therapy. They all come with different propositions in terms of need for administration. So with factor replacement, with some of the best less frequent infusions, I'd probably have perhaps to say we're down to once a week. But we still have patients that are on standard half-life products, kind of more standard extended half-life products that are even more frequent than that for very reasonable reasons. As we move towards the non-factor therapies, you can see the number of injections or infusions typically decreases, perhaps with the exception of concizumab, which is a daily medication. And then certainly gene therapy. It says one for life. One for the life of that particular product. We don't know that those gene therapies, and highly anticipate those gene therapies that are currently licensed will not endure for the life of the patient. But we may need to think about other strategies, either for redosing or other strategies for a next approach to gene therapy. Then highlighted a few comments about each one. So the downside, or one of the challenges, of course, of factor replacement is that we can only administer it IV. Many approaches, decades ago and more recently, to try to leverage a subcutaneous option continue to prove to us, especially with factor VIII, that it's incredibly immunogenic, and certainly a lot more so when you try to do it subcutaneously. So these really are intended as IV medications so that we don't have any additional immune system challenges. But we can measure the levels. We can achieve normalcy predictably with factor replacement concentrate. So at times of bleed, at times of surgery, at times of anticipated significant hemostatic stress, we're climbing one of the 7 summits. We're doing some crazy other athletic sports or things that are going to put us at higher risk of bleeding. We have great control and expectations with these factor therapies. I think, I could be wrong, but I think we've really sort of maximized the extension of circulation that we can likely achieve for either factor 8 or 9. So I really don't anticipate that we will see many more novel factor concentrates specifically with enduring half-lives. But probably 52% of the people in this room may prove me wrong. So here's hoping. With factor 8A mimetics, certainly, antibody therapy, and that will extend to the rebalancing agents as well. antibodies tend to last longer in the blood. They have much longer half-lives. So the benefit is that often requires less frequent dosing. The downside is that also requires a longer washout. So if we're trying to get to no effect of, say, the factor AA mimetic on our traditional laboratory assays because we're switching to gene therapy or we're switching to a factor concentrate, we may have to wait 5 to 6 half-lives or 5 or 6 months before that effect is eliminated. And similarly with the other rebalancing agents, longer to wash out. So if we're having complication or we want to switch over to therapies, just something to keep in mind about the presence of that medication as we are ultimately potentially switching to another agent and the relative impact that may have on our pro and anticoagulant balance. So to finish my little portion of our Ask the Panel discussion, maybe Dr. Young, we'll start with you. How does the frequency of infusion and the presence of a reversal agent, if present, influence your decision or the way you educate patients on treatment selection?
Yeah, I think in particular, if you look at the rebalancing agents, there's 365 infusions a year, 52, or 6 to 12. Just on face value, you think, 6 to 12, that sounds a lot better. But I will tell you, I have a patient on the 365-day infusion schedule or injection schedule. And he's very happy being on concizumab. Obviously, he's on a clinical trial since it's not licensed. And I asked him about it. I said, does it bother you have to do this every day? And his answer was, Dr. Young, it takes me more time to brush my teeth. And I was like, okay. So he's basically incorporated it into his morning routine, and it really doesn't take him that long to do. There is the advantage that it does wash out quickly. So, there may be patients that you may have reasons why they might end up needing to get a washout. If they're, maybe they're more at risk for thrombosis, but they still want this kind of type of agent. And so you want something that can quickly come out of their system. As far as the reversal agents are concerned, so only fitusiran has that, which is antithrombin. As you look across the trials, and these trials have gone on for many years with hundreds of patients, there's been hardly any use of the reversal agent. So it's sort of like a nice to have in the back pocket if you think you might need it, but it's almost never been needed. So I would say that as far as the frequency of infusion, it really depends on the patient. If somebody's a business traveler, they're always traveling all the time, and they don't want to be carrying supplies with them and pens and needles. That person probably is not ideal for a daily injectable drug. They're always going through the airports, have to explain why they're carrying needles and things like that. Maybe for somebody like that, something less frequent makes sense. Whereas somebody else, they may feel more comfortable if they're doing something every day. So, our patients reflect, all of us, which is we're all different. We all have different ways of viewing things, different lifestyles. And so I think I actually kind of like that we have all these different dosing schedules and different possibilities. They're not all exactly the same molecule, kind of like the standard half-life factor VIIIs that are all more or less the same. And so it gives us flexibility in individualizing patient care.
Absolutely. Frequent travel, but also where they're traveling. So what is the medical system on the other side of
Sure.
where they're going to be that may be able to support them if something happens? Dr. McDaniel, from your perspective, a little bit of a different center patient population, how do you evaluate patients and think about the individualization of therapies? What are some of the features that you hone in on?
It's one of the amazing things about HTCs is that we know our patients and our families so well, for good or bad. And I think we all have families who are early adopters who want the latest and greatest, and families who want to wait and see, sometimes for a very long while. I, as I mentioned earlier, try to take the opportunity at comp visits to ask the patient and parent, how are you doing? How do you think you're doing? Are you getting all the treatment that I think you're getting? If not, what are the barriers to, receiving routine prophylactic treatment? We also, of course, would review any interval bleeds since their last comp visit. So I also make an objective evaluation of how I think they're doing. And if I have a patient who's having multiple breakthrough bleeds, even if they think they're doing fine, I think that gives me an opportunity to at least discuss, could there be a better way to manage, and what are the barriers that you're experiencing that are, causing you to bleed? We also will, evaluate their joint health with our physical therapist, with ultrasound. Are we seeing other indicators that their current therapy is just not adequate? As a pediatrician, and I'm sure this extends into the adult lifespan as well, but the other thing that I think about is, where is the patient in their life? Are they independent with their treatment? Is their parent the one giving everything to them? And is there any role for transition to an alternate medication that might allow them to be more independent with their prophylactic treatment? So my kids that are going to college, we want to equip them with all the tools that they need to continue to care for themselves, in college and beyond. And then, for me, I think that when we're thinking about these new agents, they're going to be new to all of us, but, especially to people outside of clinical trials and academic centers. So what is my comfort level and familiarity with the product? There's going to be a first patient for everything. And, having a good network of people and reviewing, the data to have a plan in place no matter what happens for your patient. And then the last thing, I think, coming from a non-academic center especially, is just, are there those monitoring concerns? Are there access, is there access to certain labs or things that I may need?
That's excellent. As we conclude this portion, let's just take a quick snapshot of clinical outcomes of approved therapies. So we start factor replacement, the standard half-life, extended half-life. Prophylaxis has absolutely led to improvements in joint health, reduction of annualized bleed rates, improvement of quality of life. Still, though, exposure to exogenous factor VIII or factor IX can lead to the development of inhibitors, which adds a lot of complexity and challenges, of course, to treatment. And even with our best attempts at factor prophylaxis, breakthrough bleeding can still occur. At least on the factor VIII side, where we have, semi-dubbed a ultra-extended half-life or higher factor VIII levels. Similarly, this medication has also led to further reduction for those in the clinical trials of joint bleeding and further reduction of annualized bleed rates. Certainly less frequent dosing with achievement of higher trough factor VIII levels has been achieved with this ultra half-life medication compared to our standard half-life or extended half-life. But we still have risk of inhibitors, certainly, and fortunately in the clinical trials so far of the previously treated patients, we haven't seen novel inhibitor or higher risk of inhibitor develop in this product compared to others. But in previously untreated patients or minimally treated patients, there will still be that inhibitor risk. And we actually don't have data yet on that population of previously untreated or minimally treated patients with this therapy. Still, breakthrough bleeds are likely to occur even with the higher factor levels that we can achieve. For emicizumab, as a licensed example of a factor VIIIa mimetic, prophylaxis with this agent in both the inhibitor and non-inhibitor populations have also led to demonstrable improvements in joint health for those individuals, reduction in annualized bleed rates, improvement of quality of life. Similar to the above, breakthrough bleeds can still occur. The categories so far, the medications so far in this category have not normalized hemostasis, just improved hemostasis to a more mild phenotype of hemophilia A. So we still need to anticipate and manage breakthrough bleeding and prepare perioperatively to ensure that we are achieving adequate hemostasis. In combination, particularly with APCC, risk of thrombotic microangiopathies have been demonstrated in a small number of patients. And anti-drug antibodies, even against an antibody, can occur, albeit much more rare than, of course, to factor VIII or factor IX concentrate. Across marstacimab, concizumab, our TFPI inhibitors, our rebalancing agents, in both of these trials, we've seen improved efficacy in terms of reduction of bleeding events, improved quality of life. But similarly, we aren't fully normalizing hemostasis. And in this attempt at rebalancing, careful attention has to be paid both to how well we're achieving good hemostasis, but also what the thrombotic risks may be, both in the usual baseline homeostasis, but importantly, at times of significant stress, duress, inflammation. a terrible COVID infection landing you ventilated in the ICU, a severe car accident, a major surgery, things that perturb the usual balance are going to impact these individuals differently. And we need to be prepared both as hematologists, but again, also across the multidisciplinary team to communicate how the risk benefits of bleeding and clotting may be shifting in these patients over time as we're thinking about other standard of care measures being delivered to them in an emergency room setting, an OR setting, or an intensive care unit setting. And lastly, with gene therapy, this, of course, across the various programs have for the majority of individuals led to sustained expression of factor 8 or 9 levels with reductions in annualized bleed rates, as well as demonstrable improvements in quality of life. Response to gene therapy, though, remains variable, with some for transient periods of times being well in the normal range, some even super therapeutic, others only ever achieving mild hemophilia A or B status. For fortunately a relatively minor number of individuals, no benefit at all, or a very truncated benefit. And our ability to predict which individuals are going to be in which of those classifications is poor. We aren't able up front to put people in risk stratified categories about how well for this therapy or each of the gene therapy platforms they may benefit or not. And of course, immune reactions against the AAV vector, probably other elements of liver hepatocyte toxicity, stress from gene therapies also seems to limit efficacy, seems to lead to a need or at least a reactionary leverage of corticosteroid therapy to try to alter the immune system, the reactions. And those therapies themselves have side effects that we need to take into account. I lied. I guess I have a few more questions for you if you guys aren't off the hook as yet. Thinking about shared decision-making, Cole, how has shared decision-making impacted your hemophilia management? And do you have any concerns about current therapy? Do you worry about breakthrough bleeding? And compared to maybe when you were younger, how have your needs and some of these considerations changed for you?
Yeah, so the HTC that I go to does a great job of putting all the options on the table in front of me. And then we kind of just have a big open discussion on, where I'm at, what's going to meet my needs the best. And something you touched on a second ago, and what I'm trying to learn is, these treatment options doesn't just affect me, it affects, the family, the wife, the kids. So I think it's important you probably bring the family into those discussions and see how that would, affect them as well. No, that's definitely a good point. And then about being concerned, there's always going to be a concern, I feel like being on any kind of medication, because it's like, what are the long-term effects going to be? I know on a lot of these drugs, we don't know, or we don't have any data on the long-term effects, 20, 30, 40 years. So where's that going to put me at? Honestly, we have no idea. So that's kind of scary. So the concern will always be there. And then, will it ever stop working? I've been on drugs before, with inhibitors and all this stuff, that the drug doesn't work anymore. And now you're forced to find another option. So, when is this one that I'm on now? When is that going to stop? Is it today? Is it tomorrow? Or is it 10 years from now? So it will always be a concern.
I think those are really important considerations. So we will ultimately move on to a panel discussion and some question and answer from you. But before we do, we need to find out what you've learned, hopefully a lot. So please leverage the Slido application on your mobile devices. You can rejoin here if you've lost it. What is the primary benefit of efanesoctocog alpha for patients with hemophilia A? See, this is what you were missing before for your yeah.
Keep the stamina here.
Do you have special skills, Stacy juggling?
No, and I would demonstrate at the podium.
Oh, I can juggle later, right?
Gonna need a beverage or two. Oh, look at this packed room. Come on, guys. I need your responses. This is... so I get out of it. Or get excited back. I don't know.
Wishing.
Yeah.
Your advice. All right. Next. Here we go. Excellent. So it is true. Efanesoctocog alpha allows for once weekly prophylactic dosing. So excellent. And it is a factor 8 factor concentrate, just to kind of help identify some of these. Of course, does not inhibit inhibitor development. And still you see it mitigates some of the peaks and troughs. You don't necessarily see the same exact swings that you do with the standard and extended half-life concentrate. But really the once weekly prophylaxis is, I would say, one of its best benefits. All right. Which non-factor therapy uses silencing RNA to block antithrombin? Oh, we're going like fire here. Everyone, their application open. They're ready to go. All right. But yeah, we hit 55 last time. We could do it again. I'm confident in us.
This one's easier. Should get past 55.
So close. 4 more brave souls out there.
All right.
Yeah. We got it?
Yeah.
All right. Excellent. Majority got it. Fitusiran, silencing RNA against blocking antithrombin. And then I think, all right, which of the following therapies does not require weight-based dosing? This was a tricky one.
All right, I think we're good to go. Yeah.
Right. Excellent. Marstacimab, loading dose, standing maintenance dose. Very good. So some key takeaways. The therapeutic landscape for hemophilia is rapidly expanding, as hopefully you know, and we further demonstrated for you. Many new products, both licensed and also still undergoing clinical trials. Each class of these therapies is associated with benefits and risks, and it's really important to discuss these with patients, with caregivers, and really engage in shared decision-making as we're making both prophylaxis and treatment options. So with that, I will turn it over to Ms. Moss for our panel discussion.
Thank you. So my first question for the panel is, like, when I think about when I started in hemophilia 30 years ago, and we were exposing kids, especially to factor 8, especially in that early treatment period, the risk of inhibitor development and monitoring around inhibitor development was really part of something that kept us up at night and during those early treatment periods. So we'll start with Dr. Young. Like, how do you look at patients who maybe they've been on emicizumab and their first exposure is at 3 years of age or 5 years of age, or they don't get to even 10 exposures for a long time when they have a bleeding episode and you do give them factor 8?
It's almost like you're plugging my poster, but I don't think you knew about that.
Did not know.
Yeah. So yeah, I'll plug it now. I mean, there's a poster on Sunday evening which looks at the Haven 7 trial and looks at exposure days over time and you know, what is the inhibitor development. So if you're interested in kind of the details specifically to emicizumab and then getting some exposures to factor 8 and what is the rate of inhibitor development and when did the inhibitors develop, I mean, you can stop by that poster on Saturday. I mean, the short answer to the poster is that it's just the preliminary data, and it's going to take a while for us to accumulate enough data of patients on emicizumab or getting exposed to factor 8 to really know, you know, what is the rate of inhibitor formation in those patients. I mean, it's going to probably be another 5, 7, 8 years. I mean, the PEDNET group, which is a European consortium, is really looking at that through their large database and network, so we may get some answers sooner. I think if somebody started emicizumab when they were young and they want to switch to a factor 8 product, like we talked about the UHL product, we've switched some patients from emicizumab to that because they were having some breakthrough bleeding and they were playing sports. the patients we've switched so far have been heavily pretreated. They'd had factor VIII a long time. So it'll be some time before we get these younger kids who, have had 10 years of emicizumab or similar product and then want to switch. So I really we just don't know what will be the risk for inhibitor to those patients who've not gotten to the 50 exposure days, which typically is when the inhibitor formation starts to really essentially go away completely.
And when you have a drug that has a ultra long half-life, how do you count exposure days? Is it still just one for an infusion?
Yeah, I mean, so the short answer is yes. That's kind of how we count it. Does an exposure day to efanesoctocog alpha equal an exposure day to a standard half-life factor VIII? Immunologically, we don't know the answer to that.
Yeah. And Stacy, for you, when you've had a patient, for example, who's had an inhibitor and the inhibitor goes away because they haven't been exposed to factor VIII, how do you think about their next, if they have a surgery and they need an infusion, what are your thoughts going into what product to use and that sort of thing?
Absolutely. So most individuals with high titer inhibitors also have high responding inhibitors. And so that with representation to additional factor VIII, likely, depending on your agent, I suppose, but after, 3 to 5 days of exposure, I would expect that titer would increase again. And so we talk about that with patients and families. And so for minor things, we often will leverage bypassing agents for recombinant 7A, for example, because we have good overall efficacy. And if it's non-life-threatening minor, it helps avoid the potential trigger of that inhibitor titer and then save exposure to factor VIII for airway-related surgeries, CNS surgery, severe bleeding, and things like this. But I think once you've demonstrated for an individual that their titers tend to wane over time, it does change the opportunity to discuss leveraging factor VIII concentrate with hopefully an opportunity for many weeks or months following that exposure again for the titer to dwindle. So that you may actually, even without leveraging ITI, be able to periodically leverage factor VIII concentrate even for those individuals.
Cole, how nervous are you for inhibitor development or inhibitors to come back? Like how much on your mind? You mentioned you've had an inhibitor for infusions when you have bleeding. What are your thoughts?
Yeah, I feel like I've been living with an inhibitor for so long. I mean, I don't even think about it much anymore. But yeah, I feel like having an inhibitor makes things more severe, makes the recovery time feel longer, makes the medications more confusing, more phone calls to the HTC to figure out the dosage. And yeah, inhibitors can create a lot of problems. And yeah, it's always on your mind.
Yeah. Jenny, I do have a question for you. When you have a new patient, a naive patient, like someone in Cole's case where no family history, there's no experience, and you start talking about the therapeutic landscape that you mentioned earlier, how do you start to approach that in this family with really no background information?
Yeah, we all know that can be so overwhelming, just the diagnosis itself, much less thinking about the myriad of treatment options that we now have. And, I think just, again, trying to meet patients and families where they are, understand their distance from the hemophilia treatment center, their, willingness to do certain therapies. I mean, some families are highly averse to seeing blood or needles or, and so just thinking through all the logistics of how we can best provide some sort of prophylactic therapy for that child. I think just highlights the need for ongoing support through the HTC for education and evaluation of how we're doing along the way. But the reality is there are multiple options that are completely reasonable for a newly diagnosed patient. They do vary pretty significantly in how they're administered and the frequency and things like that. And so just try to have as much of an informed discussion with the parents as possible and make the best decision for each case.
Great. This one's for Stacy. I know we've talked during this presentation about the ease now of starting someone on a prophylactic regimen, whatever that is. How does that influence your threshold for starting prophylaxis on, let's say, a moderate patient or a mild patient. And I think this is kind of in that we're finding that they do develop joint disease, and it's really become a topic that we're talking about more.
Absolutely. So I think that the challenge is the proportion of individuals that develop joint disease, the severity, and the time course. So certainly mild, moderate, severe, any patients that are demonstrating recurrent overt bleeding, either traumatic or spontaneous, have earned prophylaxis, in my opinion. And it tends to be true, of course, that the lower your factor 8 or 9 level is, the more likely you are in that category. So moderates, obviously, factor 8 usually in the single digits at best, higher single digits in the mild category. And so I don't think we should be excluding the concept of prophylaxis just because from a laboratory perspective, he may be labeled moderate or mild. I think which factor concentrates or other therapies we use may be informed by that baseline level. So if your baseline level is already 7%, for example, it's going to be very difficult for me to contrive a standard or potentially even an extended half-life regimen that reliably keeps you above your trough. You're going to need something a bit more. And so for those individuals, something like an ultra half-life factor 8 or the more extended half-life factor 9s or a factor 8A mimetic may be of better benefit, really trying to alter their sort of baseline hemostasis.
Jenny, I know you mentioned that a lot of your patients are in rural communities, or does that influence the product that you might choose? Like, for example, if you know a patient has less resources, would you think of an ultra long half-life versus the need for a little more frequent infusion during bleeding?
Yeah, I think that absolutely plays a role in decision making. And there are, certainly some very competent and savvy families that live in rural communities who are capable of doing infusions multiple times a week, but that's not the case, every time. And certainly my goal is to try to provide the best bleed protection for the patient, however that may be achieved. And so for some families, yes, it is choosing that ultra extended half-life factor product or a subcutaneous factor 8A mimetic, that allows them to, be consistent and adherent and receive the prophylaxis that they need.
Great. Thank you. Okay, well, that's all I have for my panel discussion, so I will turn it over to Dr. Young.
All right. So we have a Q&A. We've got some really good questions here. You could still ask questions through the Slido, or if you have cards, it's kind of old school, but if you've scribbled one on a card and want to put your hand up in the air, somebody will come and grab it. Let's see here. I'm trying to group them a little bit. There's two on emicizumab. Let's start with this one. And this could be anybody on the panel. I'm not going to direct to the questions, so just feel free to. There's some directed to Cole, so we'll get to those in a second. But Cole, you could chime in on any question as well. So for patients with inhibitors who are on emicizumab prophylaxis, what are your protocols to support them through major orthopedic surgery?
So presently, we leverage primarily recombinant 7A to get them through surgery. And to be truthful, it's very similar, I would say, to what our protocols have always been. Since we don't have a reliable hemostatic laboratory assessment, a lot of it continues to be based on clinical outcomes and bleeding. I would say that knowing that rather than being in the severe range, that they are somewhere in the mild range. For argument's sake, we often will sort of guesstimate, say, 15 to 20%. That often allows us to begin weaning how frequently we're administering the recombinant 7A a little bit more liberally than we might if we know that they're otherwise severe. And generally we'll wean a little bit more quickly, but still generally provide ongoing hemostasis for the same 7, 10, 14 days, depending a little bit on the details of the surgery and how well we've achieved hemostasis and if there's any complications or what have you.
And we generally take the same approach using a 7A product initially. We have had one patient who just did not respond as well. And so, utilized BIBA, below the dosing threshold in that case, but generally a 7A.
All right.
I would just say it's important to recognize, right? So even though, of course, we have a black box label and we know that some individuals who received APCC did have thrombotic complications, certainly not all. And so you have to treat the bleeding. So with sort of careful decision-making, looking at the dosing, that's absolutely the right approach, of course.
And another one on emicizumab. How often are you monitoring for inhibitors in your patients receiving infrequent factor while on emicizumab?
I was actually going to ask the same question to you guys.
To me.
And I think it's so hard to know with the infrequent dosing that many of our patients have. We generally do check at least annually, but then I also just have questioned after an exposure, should we be having the patient come back to check sooner than their annual comp visit, additionally?
Yeah. I mean, I think, the standard has always been 3 exposure days. Then somebody asked about Altuviiio, and is it the same kind of exposure day situation? And because a lot of our, I should say efanesoctocog alpha, not to use brand names, shoot me later. But what I was going to say is that for efanesoctocog alpha, for patients on emicizumab, a lot are on efanesoctocog alpha for breakthrough bleeding. So then what do you do? I think, if you do it every 2 or 3 exposure days, which is probably not going to be very often, even if it's a standard half-life or the other extended half-life factor 8s, then I think that's fine. We're still learning this as we go, to be honest with you. Do you have any standard, Jennifer, for example?
Yeah, I mean, we have flow charts that kind of look at where were they before. Do they have a history of inhibitor? Did they look, how many exposures have they had over their lifetime to factor 8? But a lot of it is going back and checking after a bleeding episode and seeing where they are. Fortunately, we don't have a lot of those, so that makes it easy.
I would say similarly, for those with less than 50 exposure days, every 2 to 3 exposures or annually, even if it's 1, we'll keep an eye on inhibitor titers or pre-procedure. So if they've had 1 or 2 exposures and now 4 months later, tonsils need to come out or something like this, we would take the opportunity to assess for an inhibitor titer prior to that kind of event.
All right. Along the same lines, a former inhibitor patient, so think about your patients who had an inhibitor, they're now tolerized. And they switched to emicizumab, right? So it's a patient who had an inhibitor, he stayed on, it was tolerized, has been on factor. Now they switch to emicizumab. Do they need to receive factor 8 infusions in some periodic fashion to quote unquote maintain tolerance?
There's no evidence that is true or helpful as yet. Certainly potential that someone could design and execute that as a clinical research, but I would say in regular clinical practice, there's 0 data to suggest that that's needed or beneficial. I think, though, the conversation often comes up with patients and families, well, what is my risk of a recurrence of my inhibitor in the future? And I think some of that can at least be informed by the characterization of their initial inhibitor experience and ease with immune tolerance induction. So those that were very difficult to tolerize, have particularly high inhibitors, may potentially be at higher risk for recurrence. Those with lower titer, easy to tolerize inhibitors, their immune system is different, their body different, exposure to 8 in the future is different, probably at lower risk.
The albeit limited data published, I think Emory, it was Dr. Batsuli published this, or somebody from the Emory group, where they looked into this and they didn't see any recurrences. Now, it's a small group of patients, all for a limited period of time, but at least for that, they didn't see any recurrences. Can I just ask with the AV guys, can we just turn the timer off? Because it's like flashing red in my eyes. It's driving me nuts. Thank you. I got the time here. We got 12 more minutes for questions and then we'll close. So we can perfect. Thank you very much. Let's switch to efanesoctocog alpha. There's one question here. I'll just take it because it's quick. Is there a indication for efanesoctocog in von Willebrand disease type 3 or 2N? There is no indication for it in those conditions. When you say indication, I mean like on the label or anything. Could efanesoctocog be used to help something like type 2N von Willebrand disease? I think it's a fair question, and I think there are people out there who are looking into the question of using efanesoctocog alpha in von Willebrand disease. Specifically, obviously, it's only going to raise the factor 8 level, clearly. And so that's where kind of the rubber meets the road on that. But as of now, I would not recommend using efanesoctocog alpha for anybody with von Willebrand disease unless it's in the context of a clinical trial.
But just adding, similar to as we've started to see with emicizumab, leveraging in a research perspective, leveraging emicizumab in von Willebrand disease, which also still only improves the factor VIII. That's where the rationale and clinical opportunity to investigate further remains.
And then so another question about efanesoctocog alpha. Somebody asked, why is efanesoctocog alpha listed as a UHL for Hem A, but weekly for Hem B? They mentioned one specific product, but any of the factor IX products, why are they called EHL, even though they're also weekly? I mean, I think it's just differentiating, right? So with factor VIII, we have the bucket of standard half-life factor VIII, which we all know is, typically 3 times a week. I know some of them are approved for 2 times a week, but we kind of know what those products are. Then the specifically modified extended half-life factor VIIIs that were shown on the screen earlier, there's 4 of those. And I think it's pretty clear and obvious that efanesoctocog alpha is in a different category of factor VIII, given its half-life is much longer, the levels, et cetera. So, I mean, we just, for this talk, put UHL there. I've written UHL, I think, in one paper, a paper that's going to come out soon. That's not a standard term at this point. I want to be clear about that. I think somebody in SSC, they're working on some sort of standardization for these terms. But the reason is really more to differentiate 3 groups of factor VIII from 2 groups of factor IX. We're not saying that, U or whatever, or E for the factor IX products. We're not trying to be picky that way. There was another question that I'll turn to the panel on. I'm trying to keep things, unfortunately, these don't delete as I ask them. Okay, so here's a question for the panel. Efanesoctocog alpha has been a huge help for moderate hemophilia, not on prophylaxis, and I'll add even maybe mild hemophilia, not on prophylaxis, but due to undergo surgery, so repeat infusions can be decreased or eliminated. Thoughts on that?
True. 100%.
Yes.
Yeah.
I found it to be just so helpful in managing those patients with moderate or mild hemophilia who are not on prophylaxis and not competent with, their own self-infusion, because they can get by with oftentimes just a single infusion.
Yeah, and it is licensed for surgery as well, and you can see that in the prescribing information in the U.S. I think it's similar in Europe as it's being licensed. One question for Cole. Cole, how easy is it to get medication that you need? Is it delivered to your home? Are there issues with access?
Yeah, we have an amazing system, at least with the HTC I'm at. Everything gets delivered to my door every single month on the same exact day. They have a whole pharmacy team that's always reaching out to me, asking if my medication's expired. What do I need? Do I need supplies? No, so there's no issues there, ever, really.
Yeah, I mean, I think it depends on where you are in your health system. I mean, it's generally in the U.S., we can get drugs to patients pretty quickly, through deliveries and things like that. So here's a little more controversial question. I know how I would answer it, but I'll answer last. Antithrombin levels of 15 to 35% are scary. How are you prepared for severe infections? All antithrombin assays are not the same. Which assay is preferable? So why don't we start with the first one? I should have asked them separately. Antithrombin levels of 15 to 35% are scary. Let's start with just even that. But the hyphenated part of the question is, how are you prepared for severe infections? So you can take one part of it or both parts of it.
Sure, and I would say infections maybe / major surgery when you think about sort of inflammatory elements and things like that. The low levels of antithrombin in that range sort of are more scary. It's a more significant thrombophilia, of course. It is mitigated in our hemophilia population, right? Thinking about that rebalancing element to some extent by the low sort of factor 8 or 9 levels. And so I think as we have additional patients within this range, I think the 15 to 35% is certainly less scary than pushing everyone to less than 10%, for example. So I think as we continue to gain experience in this category, looking at minor surgeries, major surgeries, infections, and things like that, we'll continue to learn for both the individual sort of and the collective what the overall thrombotic risk is. And I think to some extent, though important to focus on antithrombin, it's more measurable. It seems more familiar to folks. This really also extends to the TFPI inhibitors as well.
Yeah, and to me, the antithrombin we can measure. We have antithrombin concentrate. So yes, I mean, I certainly think about it, but it's more tangible than thinking about TFPI and the impact, there to me.
Yeah.
I think it shows just the more importance of how fragile they are, and to maybe those aren't the best patients to have a procedure outside of your institution where you're not watching them and don't have that added level of concern.
Or individuals with additional number of comorbidities or things like this. Yeah.
So regarding this first part, when I first read this, antithrombin levels of 15 to 35% are scary. My thought was factor VIII levels of less than 1% are just as scary. And so obviously this is the whole rebalancing thing that we spent a lot of time talking about. I'll answer this one just really quick, just so we can get to other questions, and we're sort of, we got a few more minutes left. All antithrombin assays are not the same. Which assay is preferable? So there is a publication, recent publication about a field study that was done in patients who received fitusiran. And so the assay that's been used in the clinical trials, and I do have to use a trade name here, so sorry, is the Siemens Innovance assay. That is a specific antithrombin assay. And antithrombin assays differ. Some of them is checking the inhibition on factor 10A. Some of them is checking the inhibition on thrombin. Some use bovine 10A. Some use human 10A. It's not as simple as just all the assays are the same. So the assays are different. And the only one that has been really the most accurate, and that's the one that used in the clinical trials, is the Innovance assay. I do suggest you take a look at that paper, and you could find it online through your usual searches. One more here is, and I'll turn it to Stacy, says Dr. Croteau, or me, but Stacy, how reversible is fitusiran? How quickly could you switch a patient off fitusiran to another product? Let's start with that.
Perfect. So the half-life, of course, of fitusiran is long. So in terms of how long does it take fitusiran to clear out of the system, it's on the order of weeks, of course. When you think about reversibility, if one actually needed or wanted to reverse that, you certainly could administer antithrombin concentrate, remembering, of course, that the half-life of that antithrombin concentrate is much shorter than the half-life of the fitusiran. So if it were even appropriate to do that, you'd want to continue to monitor very closely clinically, and depending on the clinical situation, one dose may not be enough if you needed to do that. And so I think ultimately, if someone decides for whatever reason that they want to switch from fitusiran to something else, there is sort of a washout there. So careful look at both how the antithrombin levels are changing over time, and then of course what agent you're switching to would help inform sort of the timing of the switch and the levels one would want to achieve before switching.
And I'm going to, with significant amount of shame, plug another oral abstract. So my team, actually it's my junior faculty member, has an oral abstract that's looking at mixtures of what it would look like in the plasma if you have trying to switch from emicizumab to fitusiran, really, or vice versa. So if you're interested in that, that'll be tomorrow, sort of in the midday oral abstract session on hemophilia. Okay, so here's another question. There's no reversal agent for marstacimab, and so by extension, I'll also say concizumab. Is that a concern for unplanned surgeries?
I wouldn't say that's a concern, but certainly something to think about. The half-lives there are less, and so depending, again, on the details of the surgery and the individual and what you're doing, the washout could be a little bit faster. And so as you're making your perioperative plan, that would give you a little bit more flexibility in that regard.
I also, was just curious about the hemostatic balance in general. And, if we think about using these coagulation rebalancing agents and the patient is in this high inflammatory setting or septic or whatever, is there going to be a role for anticoagulation in those patients? I think historically there probably has been some reservation in our hemophilia patients, but, I was just curious about thinking about the hemostatic balance and the role for anticoagulation and also potentially concurrent factor therapy, and I don't know if you have any experience or thoughts about that.
Are you asking me?
Well, I think truthfully, the answer, at least from my perspective, is we do. I think those are all important considerations. From my perspective, we do have to learn more because those are not the situations that we've been consistently faced with in the clinical trials, and even amongst those who've had thrombotic events in the different clinical trials, it tended to not even be in those very rare situations. It was a combination of other risk factors. There weren't a lot of similarities in many cases across the patient profiles that led to the thrombosis. So I do think that that's still a very gray area that we have to be upfront with patients and our colleagues about, and where we need to learn more collectively.
Yeah, I think, tissue factor pathway inhibitors are a really complicated molecule. I don't know that we even understand entirely what happens during surgery. And so, I think we go with the trials. There's been surgeries on the trials. They'll be presented once they're ready to be presented. And I think we just need to go with that. I was going to get off this topic and get to gene therapy. Just 2 questions. I know we're just about out of time, but we'll have time for these other quick questions. But there's one more. Asking me, would fitusiran benefit a patient with hemophilia C? I assume you mean factor 11 deficiency, less than 1% with many bleeds. Maybe. Yes, these products that are rebalancing agents are, they're obviously not correcting a specific factor deficiency. They're not mimicking a specific factor product because they're working on the other side. And so I think the idea that these could work for bleeding disorders other than hemophilia A or B, like factor 11 deficiency, or even outside of that, is certainly very an interesting proposition. And I'm sure that we're going to see studies looking into that for these different agents. So on to just a couple on gene therapy. How do you inform your patients about the risk of chromosomal integration? Because the risk is not zero.
Absolutely. So I think, to be honest, it is information of things that we know and that we know/don't know. So not only the low rate of a high number of chromosomal integrations, but also remembering that while we prefer the gene therapy to go to hepatocytes are also not the only place that this gene therapy is going and being taken up in. And we've seen that across other disease studies who've been looking at other tissues and things like that. So I think being upfront about the known risk and the fact that we haven't as yet seen any integrations resulting in neoplasms or cancers, that it continues to be to some degree an unknown, but that we've had a lot of gene therapy trials in hemophilia and in multiple diseases as yet that haven't demonstrated integration in a meaningful way leading to a cancer diagnosis is sort of the best information that we have at present.
Yeah, I mean, there's been malignancies reported in the clinical trials, and all of those have been evaluated in extensive detail, and they've not been shown to be related to the AB vector insertion. One more, how would you contrast clinical trial profile of hemophilia gene therapies, valactocogene roxaparvovec versus the phase 3 giroctocogene fidelparvovec? Well, they're going to present the phase 3, I believe it's Monday afternoon, they're going to present the phase 3 trial for giroctocogene fidelparvovec. So I think the answer to that question is ask us after Monday afternoon, because I think, I read that abstract, but I don't want to, it really shouldn't discuss it until it's presented. So I'm going to reserve comment, and I'm going to ask the panel to reserve comment. The last, it's not really a question. I'm sorry, I skipped this one. Well, never mind. We're running out of time. Somebody said, with all the new treatments, isn't it time for a platform trial? Yeah, absolutely. And I'd be happy for you to design it and let me know what it might look like. I mean, it will be really difficult to do that. I take the point. It's a good point. Lots of trials, basket design, just fill the patients in there and, see where they go. But I think it would be really difficult to do that. All right. I'm a believer that meetings should start on time and end on time. I stick with that. I'm also a believer symposia should start on time and end on time. It is 1 minute before we're done. I want to thank the panel for doing a fantastic job and all the presentations. Thanks to Sanofi again for the grant to allow us to do this. You can get this slide has been up for a while, so for those who need CME credit, here's your chance. I want to thank the France Foundation, who is the medical education company who organized this. They've done a fantastic job. And I want to thank you for coming, and I hope you enjoy the rest of ASH. It is exactly 1 o'clock. Take care.